So am I. And you're alive. Thank you. We're back. Senate Health and Welfare. We are continuing our walkthrough and decision-making process with our committee bill, and we are on page 8, Sec 4, budget review.
Okay. I don't know, Madam Chair, if you want to visit any of the sections we've been to since you got testimony from AHS? Or
I don't
just
think so.
move forward?
I don't think we haven't gotten just the data section yet, so that.
No.
And we let's keep going through and then we'll go back.
Okay, because the thing I heard them was just leave Medicaid alone.
Yeah.
Yeah.
But I think we are.
I think, yeah.
Yeah, no, we are. And, but Jen, there was a suggestion about changing some underlying statutory language.
Yeah, they said, at least in the version they gave me, they're proposing striking out existing law, some existing law language around the board's duties to focus more specifically on what you're doing in the bill, but I don't know that it makes sense to necessarily make changes around the board's general rate setting authority outside of the reference-based pricing context,
Right,
unless and until you decide to take.
right. That's a
Steps
whole
there.
other discussion.
Right.
If I can
Yeah, please.
have the
Norm.
record on them, I think their issue was, it says the board shall have the following duties. And under A, it just says, participation in Medicare and Medicaid. And I think that their whole thing is they don't think the board should have any oversight of
But
Medicare.
that's it's provision of existing law, and I don't think.
Right,
this is
that's a bigger
time-
discussion that we
right.
have not had
Okay.
yet.
It's about implementing methodologies
Yeah.
for achieving payment before and
Got
containing
it.
costs that may include the participation of Medicare and Medicaid.
Right.
I don't know that this is, this is right, so I don't think this is not what you have been focusing on, and I would be uncomfortable making changes where you have heard. Okay. So section 8 is the budget review. And so this is the board's existing section of statute on the Vermont Care Board's hospital budget review process. So the first thing that's in here is the uniform system of accounts language. I think given what we have talked about, both amending in the previous section to be a little bit less prescriptive, but talk about the kind of standardized approach and the potential to put in a kind of consultant review of how to make that work. I don't think you need this language in A anymore.
Okay,
Strike that.
and so those three sentences, the 3 lines. Oh,
Yeah, I think because you're gonna say in the
Oh, right,
Hospital
we're doing it.
filing information language that they will be
Okay.
that they will
Yeah.
submit information as directed by a board to maximize hospital budget data standardization. I don't think we also need to say here that they will require. So I don't think there's anything added by that. All right, then we have. Yeah, so then I will be adding once established about considering the statewide healthcare delivery plan. I think somebody somewhere had a concern about the language around, might have been about consulting with the Agency of Human Services, but I don't think that's an issue. They're just
No.
consulting
Right.
to ensure compliance with federal requirements, etc. Keeps everybody properly in their own lane. All right, number 7. Lines 4.
Yeah, that one.
Oh, yes, so number 6 was the hospital network. Financial operations for a hospital that operates within a hospital network, the board supports, and I'm not sure you've heard any. I don't know, didn't hear anything otherwise.
Do we need that there? Do we put that in with section 5?
No, I think it makes sense here because you're talking about a
Okay.
hospital that you're talking about the budget for a hospital that operates within a hospital network.
Okay.
So looking at the aspects
Right.
that relate to the budget of the individual hospital.
Okay.
So number 7, is, yes, we talked about moving to section 3. Well, we talked about moving to section 3 or striking. There were various proposals. Sorry, this is about developing hospitals or developing incentives for hospitals to support community-based, independent, and non-hospital providers. So
The development piece was
right, so the
developed. So,
board wanted to move it to section 3.
yeah,
The Office of the Healthcare Advocate didn't want it at all because they want the hospitals to focus on providing hospital care. And the Medical Society had proposed language that I have somewhere.
if we would review incentives, so if we review
Versus development.
if the hospital.
The Medical Society had language that you and I had looked at last night around excluding revenue derived from those services. Excluding that from net patient revenue and total cost of care.
Got that. Yeah, that makes sense. And if we, instead of develop incentives, if we said review incentives,
Who's doing the incentives?
Right, I think the idea was to move to section 3, the responsibility to propose ways that they can support those community-based, independent, and non-hospital providers. And then we could put language in here that would exclude any revenue from those proposals or those programs from their net patient revenue and total cost of care targets.
that makes sense.
We can look at that for a new draft. Just keep track of those comments here. My draft, so I think there were some proposals from various parties to strike some provisions of existing law. Have not done any of that. Although certainly can if there are pieces that the committee wants to strike.
On page 11. What about?
So I know that the board had some suggestions around around the salaries and putting in net hospital network pieces here. I think it makes more sense to group the hospital if we're going to be looking at hospital network outside of the context of an individual hospital budget. I think it makes sense to do that in the hospital network section and not kind of blur regular individual hospital budget review with hospital network review, because they're not, most of these won't apply. To a network. So I think those concepts can make sense, but let's use them later. The board did also want to add something about reviewing variable payments and incentive plans for executives. So I can add in some language on that for your next draft. For number 17, the number of employees, consider the number of employees whose hospitals are whose duties are primarily administrative in nature, with those whose duties primarily involve delivering healthcare services directly to hospital patients. The
Period.
board, and yes, the board and others proposed getting rid of the rest of that sentence about national average staffing ratios. It didn't really have that kind of
So where it says as well as. to
right.
the
So
end,
just
get rid of
exactly delete from the middle of line 6
Yeah.
through line 8. Does anybody have strong feelings otherwise? Okay, we have individual hospital budgets established under this section must be consistent with the statewide healthcare delivery plan once established. The board wanted and shall consider rather than shall be consistent with. I think the chair suggested shall be consistent with to the extent practicable, which is probably, I mean, I think you're directing them to consider the plan, or consider a lot of things, so you're right, consistent to the extent practical. May make sense while giving them some flexibility.
That's great to me.
Presence.
The variable language you all.
Yes, that's right, there's, and they wanted the variable compensation language here
That's on page,
as a number 8
yeah.
for those suggested. And then we have the global hospital budgets. So a few things here, first, just say beginning not later than hospital fiscal year 2028, so that there's that flexibility for, complying with the requirements of the head model. So I don't know if you want to say not fewer than 5 Vermont hospitals, or if you want to give more flexibility than that.
The suggestion was made to give more flexibility based on the work that's going on, so. I don't know
We
how
could
to
say,
say it.
we could say for 1 or more
Okay,
instead of not fewer than 5.
yeah. let's do that.
Or better not, and then keep the carve out for critical access.
Yeah.
Hospitals at least. And I believe we've heard we need to specify that this does not apply to Medicaid. We don't know, we need to refer to Medicare. I mean, yeah.
So it's
We-
Medicare to the extent
Medicare
that
to the extent-
it relates to a head.
I think we probably want to be less specific, like
Less
to the
specific,
extent
okay.
permitted, or to the extent,
Okay,
yes, permitted under federal law, something like that.
okay. And we carve out Medicaid.
Right.
Yeah, okay.
All right, then we have some outcome measure language. I think the board had had a suggestion, and the medical society had some
Aligned with the head model.
proposed
Ahead
language.
targets.
Sorry?
Aligned with the ahead targets.
I don't, so again, I don't know that you want to put ahead
Oh,
into statute,
okay.
because we don't want to limit ourselves
Yeah.
not knowing what will
Yeah.
happen. I think we can be a little vaguer and still, make references. But the medical society had suggested for E1, something like the board in consultation with the Vermont Program for Quality in Healthcare and in alignment with the goals of the statewide healthcare delivery plan shall establish measurements for hospital costs, quality, and access.
That's beautiful.
Sounds good.
Go ahead.
Thank you, Madam Chair. For E1, I wrote down my notes and Diane, can refresh my memory maybe. Agreement and Fair Board already does this and it might be redundant.
I think they do have some, I think they do have measurements that they use. I don't know that precludes you from directing them to
I
either
think it does.
do what
but,
they do or
In
do
this
things differently.
context,
Doing measures.
well, it's in a kind of a. new
And so maybe we
criteria,
don't
but-
say establish,
Right, why not say
maybe it,
continue?
well, yes, or, I don't know, let me look at the word establish, but if, yeah, maybe
Yeah.
there's a softer way to say that.
Changed the word yesterday to may, shall.
Michelle is important.
Okay.
I don't think that one, although somebody may have suggested that.
So I think Larry, the one you're referring to is on E2, actually at the top of page 13, the board may. I think that's the major.
Yeah.
Where is that? E2?
Yeah.
E2 on page 13 at the top of page.
Oh, okay,
13.
yeah. wait.
Yeah, no, we're not, no, I
Yeah.
was just helping Larry.
Yeah, no, that's
Yeah.
good. Thanks.
Yeah, so I found the board's comment, at least in their table. So they support requirement that hospitals implement budget orders in a manner consistent with the statewide healthcare delivery plan. I think so. Consider striking language regarding outcome measurements as the board already uses its authority to evaluate hospital cost, quality and access outcomes.
Do you mind comparing that with what's currently in statute and that that may or may
I
not
think,
be?
yeah, I think as long as we use a word other than establish,
Right,
maybe we can.
yeah,
make
it's good
everybody
to
happy.
have that embedded here.
Okay. C2 is the language that we've kind of shorthand referred to as the reverse CON. The hospital that proposes to reduce or eliminate any service to comply with the budget order have to provide notice of intent. And then there's a process. So a couple of things that you at the top of page 13, the board suggested changing the board shall evaluate to the board may evaluate.
Okay.
They also suggested requiring the hospital to explain how its proposal is consistent with the statewide healthcare delivery plan.
Yeah. So that
Instead of making the board figure it out. And so maybe what makes sense is maybe you want to include all of that. I don't, I think the idea of that the secretary mentioned, and I think we talked about before as well, about not requiring this whole notice process if the reductions are as a result of the transformation work that the hospitals were directed to.
Right.
Probably makes sense.
does.
That's just creating work for them to comply with something that the state told them to do.
If it examines the transformation work, that or things that have happened, why would we want to make that
Right.
be justified all over again?
Exactly.
Right. Got it. Yeah. That makes sense.
And somebody proposed, instead of talking about the needs of the community served by the hospital, that it just be consistent with the most recent community health needs assessment that the hospitals are required to do. That seems
Yeah,
like sort of streamlining the process, giving it by using existing.
well, what about the community health needs assessment? What is it? Why? Yeah.
So this language is about the board evaluating the proposed reduction or elimination for consistency with hospital transformation efforts, statewide healthcare delivery plan, and the replace needs of the community served by the hospital with most recent community health needs assessment. But maybe you want sort of the hospital to be explaining that as part of their notice, and then the board can review their justification.
Yeah, I mean, as long as we're exempting the work that's already
Right.
happened, and then
Right, and
this
so-
would say going
Yeah, and
forward.
so
Yeah,
maybe we don't even need to
That makes
say
sense.
consistency with the hospital transformation efforts.
I don't want to do that anyway, justify what they're doing. Got it.
Okay.
You don't want to add, but we do want to make sure. Okay.
All right, and then,
Oh, this is where we had thought about a such as kind of a clause. So when that work is going on, there is a decrease in health insurance premiums. There's services are not compromised. I don't know. We had thought about that because it might be,
yeah.
it might be,
The board
because Senator
said-
Cummings brought up the comment that, it might be canceling the services here, but then they're gonna be over there and they're
Right.
accessible.
Yes,
So-
I do think the board has some proposed language, so I will
Okay, why don't we
modify
look at
this,
that?
so I will put it into the next draft. we look at. Okay,
Okay, we're gonna get proposed language. We'll see what it looks like.
Section 5 is on the hospital network financial operations, so a few things here. I think the board suggested specifying that looking into the financial operations includes compensation. And also that the board may study or review structure of and value of the network fever monitors and make recommendations for changes to network structure.
Yeah.
So there's a few things I want to mention on this. You heard from some concerns from Boss about lack of process and appeal. I think at a minimum, we may want to specify that any action the board takes or, any sort of order or directive action is appealable under the board's appeal statute, just so that that is explicit. And you may want to add in, so right now it's to correct the hospital's network operations that are inconsistent with the principles for healthcare reform. You may want to include in the statewide healthcare delivery plan.
Yeah.
And then there's something. Consent to the chair. Oh, also adding a requirement that every hospital with a legal or financial relationship with any out-of-state entity, whether affiliated or owned, shall provide an annual accounting of any funds flow between Vermont entities and those out-of-state entities. Actually, that may make more sense in the hospital budget review. But
Yeah. Doesn't, I think,
if that's something more interesting.
well, it seems like another, does seem like another layer. We're gonna have to think about that.
Is anyone hospital affiliated with Dartmouth right now?
Yeah, yeah, and I mean, we have relationships
Right.
with Massachusetts, I would think, it's
That's right.
Central, New York, and New Hampshire, so it's not like, we're not in a vacuum here.
Right, so right, and the piece that's in the bill is looking at a hospital network that derives 50% or more of its operating revenue from Vermont hospitals. I don't think that would apply
I don't think that.
Yeah.
Right, so this other piece would pull in some reporting.
Well, look, we're gonna have to look at that,
Okay,
at the language.
Yep.
We can't make a decision right now on that.
no, but I will put it in.
Nolan,
I'll wait till Jen's done.
huh?
I'll wait till Jen's finished and then
Okay,
have a comment on the section.
okay.
Okay, the other thing to consider, and this gets a little ahead of the appropriation section, but if you're gonna expand the scope to networks, we don't bill back networks. The board usually bill back the companies that they do stuff, so you might consider some language around giving them the authority to, however we usually do stuff.
That,
Or you give them general fund, but they're not gonna bill back hospitals, insurance companies to do this work.
no,
Right, we're going to put it in.
okay, this is why we need to
Something
come
like
back
that
to
in
this
here.
one.
Yep.
Yeah.
All right, now we get to the statewide healthcare delivery plan. So a few things. One of them is, who do you want to be in charge?
So I
I've
think,
heard some recommendations that it maybe be the agency of human services.
yeah, we heard there's so much embedded right now in the transformation work and the other planning process. It makes sense. And in consultation with them, I know that healthcare advocate want to be consulted with and everybody else, so. But I think AHS. Yeah,
Everybody.
everybody with that.
Do you want to, so that's, I can move the board down. Do you want the healthcare advocate's office specifically named?
Well, they were,
Why not?
yeah, why not?
Yeah.
I mean, it doesn't hurt.
Great, and then I'll take out the reference to jointly meeting. And then,
One more
Yeah.
thing, and then you'd be given here, and a lot of the work they do is contract work.
Yeah,
So I don't know a ton about that kind of work. They're nonprofit, that they don't usually weigh on these things, but unless they're contracted to do so, usually it's the board or others. So I don't know how
Yeah.
appropriate that is, or you have money in for contracted work, or they do this kind of thing. So I just throw that out there.
so let's help us think about that when we get to the resource section, but
Well, the question, do you want them to be part of this collaboration or it doesn't really make sense?
I think they asked to be part of it. I think
Yeah, they
we should be
did. They
clear
asked.
about
They
what the expectation is regarding whether it's
Yeah.
participating
They didn't
for
say anything
compensation
about-
or not.
Yeah,
And what would be their role and who paid them?
Wow.
So,
I'm actually. We can.
to the extent that they are financially able.
I don't want to look because I think so. Maybe I'll just take this down for a
Correct,
second.
they provide value, but you emphasize the
Yeah.
value that Russ bringing to that.
Yeah.
And is that the work that they're doing on their own, or is that the work that they're doing as a contractor? Which they do?
Right, but I
And
also
who
want
pays
to look
that?
up.
Got
I think they may have. I want to see if they have built back.
They do, don't they?
So I think then
They did.
the question is, do you want to be able to build that for the work or
They do.
do?
Yeah, that's a big question. That is a huge question.
Yeah, so under
Yeah.
their
Maybe
statute,
it's better to have them on the advisory committee.
well, so far we're not paying it. for the-
We're not paying, yeah, no, so I do think that's a,
But yes, so that well, expenses under this section, there are a couple things they're directed to do in their statute. Here, I can put this. So this is the statute on VPQHC. That directs the Commissioner of Health to contract with them to implement and maintain a statewide quality assurance program. This is an existing provision and requires the DPQ to file an annual report, and then it specifies that expenses incurred under this section are subject to bill back. So we're not touching this section.
okay. Let's not touch this section.
We did not
Forget it, or otherwise touch the section.
So I think their bill back authority is limited to that work. That's on the department.
Okay. Good catch,
AHS could contract with them to do
Yeah.
work, but
right,
Right, but I think if they're being collaborated with, I don't think there's an automatic way they're getting paid.
Right.
So if their participation is contingent on them getting paid, that may limit their participation.
but they may not have resources, or they may still want to do it anyway. I don't know.
yeah, it'll be up to them.
All right. So Medical Society, tactfully pointed out that the plan can probably not ensure access to various services. We turned our brainstorming synonyms last night. We came up with build toward access, prioritize access, endeavor to make access available. But we have this in 2 and 3, both uses the word ensure. So, if you have specific replacement words, I'm happy to use them, or I can put in a few of these similar but less determinative words in the next draft.
Bill,
Well, we later build on
Oh,
some
we-
existing
oh.
work.
Strive to ensure.
I know, this is what
I mean, to ensure some, if
it's not in
print money, we could ensure, but. Right. We can't.
right, but I think her point also is that a plan can't
Right.
ensure, a plan doesn't
Right.
ensure, a plan can provide for access to. Well, the plan can plan for, just so we're talking about your ensure language.
plan for access,
Well, the
plan
plan
planning
shall
for-
plan for access, so
Planning
I
for-
will continue to noodle on this word and both 2 and
including
3.
a plan to include access,
Plan shall
to include,
include access.
to include.
I mean, isn't access in the healthcare reform principles?
I think so.
So the question is the word ensure. So we're gonna either build, or we're gonna plan to have it.
All right,
Or-
I'll keep thinking about it.
Yeah, yes, we need our,
Constructive synonyms welcome.
build toward mental health services.
Yeah.
Right, yeah, that doesn't make sense. So, all right. I will think about it and we will move on.
Keep thinking, we're gonna, there will be a prize for the best word.
That's vague enough.
address access to high quality, but I feel like that could say, address it by saying, sorry.
We don't want to do it.
All right, so we'll continue thinking there. I'll show play with the stories. Yeah, all right, found about
Expand access or the stuff is necessary to ensure access.
A plan that includes. It includes.
Right, we may strive, we may just strive for access to knowledge.
Open, right?
Includes a system
Prioritize, I have a lot of words. so
with
we'll
access.
think about
Includes a system with access. So let's keep going.
All right, let's keep going. So now we have in, same thing at the top of page 15 with ensure, so I will continue to think about that. Provide annual targets for the total cost of care. So I think, well, I should say, I think AHS wants to make significant changes in this section. Implement what they handed me. I don't think
We haven't seen that yet,
I
so
know.
it's hard for us
I
to,
know.
we're going flying blind here with that one, but
they handed it to me at the beginning of this month.
I know there was some language from the hospitals, I think, on lines, beginning of, around lines, well, it's number
Yes, so
4.
I think, yes, I think there was some suggestion to get rid of this idea on lines 5 through 9 of bringing spending in Vermont at or below national rates of gross domestic
Yeah.
product and alignment with or better than US national average, and instead do something a little bit more Vermont focused to say include reasonable annual cost growth rates that are appropriate based on the characteristics of the state and its communities, including and some things about the age, socioeconomic status, et cetera.
Well, let's look at that language and then we'll see how this goes.
All right, I don't necessarily have anything
Either
more for a couple of pages before we get to
18.
7. I get to 17,
Oh.
and actually, if this is we may not even say, if it's just the Agency of Human Services that is the one in charge, I don't think we need to say who's providing assistance. I was going to take out legal assistance, but I think we can just take out all of D.
Okay,
On page
what,
17.
that's
Because AHS is in charge, and so
So we're
we're
on
staffing.
page 17, lines 9 and 10.
Lines 9 and 10, just strike D. Strike 9 and 10.
Okay,
All right, yes, the next thing I have is on page 18 about the advisory committee, so I'll pause and see if there are other people had notes from before that.
the,
The definition of.
Yep, yes, the hospital association.
Yes, it was in the hospitals.
Said, but I think,
I'm looking at the top of A1, instead of saying healthcare system, I think you said plan, or does that work or not?
I don't know where you
I'm
are.
on page 18
Oh,
and I'm on line 5, 4 and 5. And then evaluate model the performance of Vermont healthcare system. I think it was that we're looking at an evolving plan. Oh, okay, so
It's
system.
the committee, right? The committee is an ongoing committee that is monitoring.
Yeah, okay, I'm,
But yeah, I think
Agnostic.
to Senator Cummings' point, Voss had said that the plan should define affordability so that hospitals and payers understand what they're working towards.
yes.
So I don't know if that's something you want to add into the.
Well, let's look at it and see what
We're
it's
talking about
Yeah.
affordable.
Yeah.
to whom?
Yeah,
What's your benchmark?
yes.
Where does it say?
I feel.
Oh, there we go. It is on page 16, line 17, identify.
Oh, wait.
16 or
Yeah, page 16, line 17, I see affordability. Or. Let's see affordability. So identify gaps in access to care as well as circumstances in which service closures or consolidations could result in improvements in quality, access and affordability.
Cost, can we just say
My
cost?
memory says something about health.
Right.
Insurance premium.
Healthcare
should say-
It was premiums that we're talking about.
Yeah.
And I don't
Reduction
know
in premium.
where. My note is on 15, but that doesn't mean that's where it is.
She's looking.
I know.
That's a big bill.
Is it cost?
All right,
What is the suggestion
let's-
there?
Yeah, we
Come
can
back to
go
that.
and they'll find.
Okay, come back to that.
all right, so we have the committee, the advisory committee, and I think one of the kind of fundamental questions is whether you want to create the committee or whether you, I think you've heard from the board and AHS that they would rather consult with stakeholders as they work through.
Get many committees.
We heard that there was a way that of appointments that the rural.
Yeah, I mean, it's a different, right, so there's different
Yeah.
ways that we do appointments. Sometimes we say, you know, a representative of a particular industry appointed by an organization that represents that industry, like should have, you know, a representative of hospitals appointed by the hospital association, representative of primary care providers appointed by the medical society. So I think the question is, who do you want to be
I was
the?
gonna say, what was the committee? And we ended up with everybody in the alphabet on it.
No, that was
That was
the,
the substance.
no, it was
It was
the,
the,
it was the emergency,
workers, the police,
Yeah, everybody's,
firefighters,
Two of them
board of
go
mental health,
well into the alphabet.
they, yes,
let's not get it that big.
no, we used everything but Z.
I like the idea of having organizations, yeah,
Yeah,
provide you know,
it's better than we do, but
yeah, but I'm not interested in having us be responsible for that.
Okay,
Right.
so you want to identify sort of the sectors you want represented and then have somebody from those sectors do the appointing. Is that?
And but the question would be, how big a advisory committee makes sense? And so that's actually where I started when I started looking at this thing. And I thought, you know, 9 people, that's a doable little group. Maybe 11 at the out.
Right, you had 11, I think you
Yeah.
had 2, you had the chair of the Green Mountain Care Board or designee and director of healthcare reform. You heard from AHS.
Well,
They
AHS
would like
wants to
the
have.
secretary or designee and the state Medicaid director.
Yeah,
So that would, if you include chair of Green Mountain Care Board or designee, secretary of AHS or designee, and state Medicaid director, you're up to 3.
okay.
And then you have room for,
Then we have,
11.
we could do other people, so it would be groups. The hospitals has to be there, no question. And then the question about, I'm looking at the FQHCs sitting in the room. I'm looking at the medical society in the room. Yeah,
right, but but who do you have them?
home health and mental
Home health.
based services.
yeah. I know that then, and I see Jeff is over there and I'm thinking, who do we have representing the patient population? Or how do we do
That's
that?
often the healthcare.
Healthcare advocate, yes. Laura, go ahead.
Laura Pelosi at MMR. So the Rural Health Services Task Force, I was a member of that for the Vermont Healthcare Association. That was 14 people. And that included everybody, FQHCs, you know, and medical society. So you could use that as the model. I think Jessa testified to that yesterday.
Yeah, she did.
It was,
Yeah.
and mental health, everybody was at the table. So it was 14 people.
14 people?
Yeah.
It's 14 people. So we already have 3 people that we're starting with.
Well, I assume there was somebody from the state government.
Yeah, there was Green Mountain Care Board and AHS, you know.
We're already there.
We're already.
So for the next
That
draft,
includes-
why don't I?
Why don't you look at that?
The one you heard plus the.
Nolan, do you want to be on this advisory?
Yes.
I have a suggestion of,
Huh?
Look up
You just-
Silver insurance.
I'm trying.
Commercial payers on there.
No.
Yeah.
Oh, well, yeah, look. Let's look and see what it means. We'll talk about that.
But it talks about the way the appointments work, right?
Yeah, that's all we're talking about.
Yes.
I was just.
Nolan, go ahead.
I was just gonna suggest, since you're gonna have the chair of the board and then the secretary of AHS or designee be co-chairs. Rather than have the chair of the Green Mountain Care Board, director of healthcare reform, and the Medicaid director, why not just have chair of Green Mountain Care Board and secretary of AHS or designee? So you have one from AHS and one from board.
Because I think they said, well,
Yeah, they said they want-
AHS said they
They want the
wanted
Medicaid
both
director.
They definitely want it.
Oh.
separate, you know, so that they have the
Well-
ability to have somebody from the director.
Yeah,
of healthcare reform, for
Medicaid's done a
example.
lot of work.
Well, no, my other point was, and Jen can correct me if I'm wrong. Chair of the board, director of healthcare reform, they're in statute, and the Medicaid director is. That's changed over the years, so.
We can flex on that. That's not.
Okay, I'm just trying to see, just still be there, but it'll be, hey, I'm just throwing out an idea to not be so, it should be there regardless, so just trying to think about the language.
Okay.
Okay,
I'll
so
leave
for
that to
your
Jen.
next draft, I will use the state, or the Rural Healthcare Services Task Force language, so you can,
We can look at it.
Commercial provider. We'll be at that.
Does it make sense to have commercial providers? It's a question to the room.
They paid the
it's a
bill.
big part of what you are
Yeah,
doing in the
Yeah.
bill.
Good.
So,
right, good.
Here's that point then.
I think we've gotten in trouble because we've done a lot of good
No,
things and
yeah,
haven't paid attention to what it
Okay.
costs.
And
And when you say you can be flexible, does that mean you could just have one person from AHS?
Yes.
All right. You'll do secretary or designee and that may be, you can be the, all right.
The designee might be the.
All right, and I think there was also, when Chair and I were talking yesterday, do you want co-chair? Do you just want one chair? I think you were thinking maybe the AHS person would chair it and,
they'll get along.
okay,
Co-chair, I find it very hard.
Oh, co-chairs are tough.
okay.
Yeah.
I mean,
agree.
Yeah.
who recognizes
I know.
witnesses and.
Yep, okay.
Yeah.
And we talked about, you were thinking maybe have the first meeting by February 15th of 26.
Yeah, that was my suggestion. I don't know what
To
other
give-
folks think about it.
People.
They're,
So it's just meeting, not out.
Sure. Okay.
Together as one.
And then I have a note to myself based on feedback from somewhere, but that it may make sense. I want to look at and potentially amend the certificate of need statutes to add a reference to the statewide healthcare delivery plan, since we already have the health resource allocation plan and that kind of stuff. So let me look at where it might make sense to refer to that.
okay, thank you.
Gotta keep scrolling. All right. Then we get to data integration. We got some very specific.
Sorry, Jen, to interrupt you. There was something about the Green Mountain Care Board you can't provide.
Oh, yeah, it's gonna, so AHS will provide assistance and I'll take out the reference to the legal assistance. It's the language
Got it. All
we
right,
usually
sorry.
use when we're creating
Thank you.
committees, but yeah, I forgot to mention. All right, you got some pretty specific recommendations from AHS on the integration of healthcare data. Are you comfortable with their recommendations? They talked about specifying the HIE steering committee, although I have to say, if I can phone a friend, it was unclear whether that was on HIE steering committee or instead of collaborating with these other people.
Phoning a friend.
Okay,
Okay, good. Go to friend.
okay.
Good.
All
It makes it tough for us because it's above our pay grade.
right,
You
so
know
the,
that.
so, and that's, it'll be a question for the committee as well, but right now it has AHS collaborating with providers, payers, and PQHC. You could just say, the Agency of Human Services in collaboration with the HIE steering committee, or you can add the HIE steering committee to that list.
Or anybody they feel appropriate.
Right, but yeah, well, we don't leave it too open, but yeah, I think adding
Maybe adding,
the second one. Well, and then there was a, are you still on, where are you? You're still there, okay.
Well, we just-
Okay,
okay, so you said maybe for the next draft, I will add them in and
we'll see what happens and
Okay.
you'll hear from Monica.
Jen, I'm hearing AHS and HIE steering committee and strike all else.
thank you. So that's the proposal. Is that what,
Okay, but we're eliminating VQHC?
that would eliminate, I mean, it would eliminate anybody else.
Not keen on that.
I mean, we could also say in collaboration with the HIE steering committee and in consultation with other interested stakeholders or something like that. So it's clear they're mainly working with the.
Such as. I don't want to lose the thought, because right now, I mean, VPQHC is doing a lot of quality metrics analysis, and we don't want to lose it. We've already lost the ACO stuff, so.
Yeah, it sounds like we have all others on the committee or are in the process of adding them, including VPQHC.
So representatives of those.
Correct.
Okay, you're assuring us that is the case.
Yes, I am.
Okay,
With confidence.
all right,
Okay.
we're good.
Okay, great, thank you. And then on the next page, so with the rest of it, I did not have questions, I think. Are you comfortable with their other suggestions? So we
I
would
think we have to be,
delete number 2. We would take out the best practices phrase in number 4. Revise number 5 to say clinical data and claims data as opposed to specifying VCures. Changing the interoperability language for their suggestion. And streamlining number 10 about the additional opportunities. They did have some, a couple of includings or such as, but
so did they take out, did they take out direct reference to EMS and stuff?
yeah, yes. Because they have they would leave it broader
And WIC, they took WIC, and there was a suggestion to make sure we have those included. I'm wondering, is there a such as we should have here?
So they say identify additional opportunities for future development, including new data types and larger populations.
Well, let's think about that. I don't know. The recommendation that and I'm trying to remember who suggested it, was to include EMS. Okay,
It sounds like WIC they're already doing.
yeah, okay. What about EMS providers, service providers, and interoperability for them? That's a pretty.
I think they wanted to take out specifically the interoperability piece
Yeah,
and just additional opportunities for future development.
we'll have to think about that.
Okay. In C,
I don't like taking out interoperability. That's one of the driving factors in linking, healthcare providers and services together.
so they do
So
in their
I'm not-
revised number 6, they say ensure interoperability among contributing data sources and applications to enable a unified health data space usable by all stakeholders. Does that get at your interoperability?
Okay, yeah, get there. Get there. Okay.
All right, and then in C, there was a recommendation from Vital to make it clear that, this is on the access is only to the extent allowed under data use agreements. I think it's an important clarification. All right, section 9, retaining ACO capabilities. You've heard various things on this. If you're going to keep some version of the language, I think BMS had a better way of describing what the capabilities related to comprehensive payment reform. And instead of electronic health records, it was quality data measurement and reporting. It's a more accurate description. There was a suggestion to maybe add this idea to the plan. There were suggestions to just get rid of this section entirely.
Well, and we heard from AHS this morning that there's ongoing work, so we maybe want to emphasize it, that we'd like to hear back about the ongoing work so that we're informed.
Well, we do have them reporting back. I mean, this is exploring opportunities to retain capabilities and reporting back in November.
Okay. Okay, let's hold it there.
We're happy to do it, whether it's
Okay.
legislation or not.
Got it. Okay, this helps us know that.
Remember it.
That's.
Okay.
What we can.
Yeah,
I would just include OneCare in that.
yes, include OneCare in that?
In the report back.
Yeah.
It doesn't matter if it's legislation, but
You're right.
Okay.
You're absolutely.
Yeah, I think, given that OneCare is a private state regulated entity, I would prefer to leave it with
Okay.
the Board of Health doing the reporting.
Okay.
but I'm sure it will be informed by.
May I suggest, ask, maybe it's a question more for AHS, but because one of our comments is it references the blueprint, and I was wondering if AHS was actually more appropriate.
Oh, yeah,
Yeah,
that's right, you did.
Thank you for not striking it that way.
Thank you.
Yeah, so should I
Good reminder.
change board and blueprint to just AHS?
Yes,
Okay,
please.
thank you.
See, we forgot this stuff.
You get a lot of comments.
Yeah.
AHS, okay. Great, thank you for the change. All right, now we get into the positions and appropriations, and then Marilyn has,
Oh, no, you have something?
thoughts, questions, positions and appropriations.
Sure.
Otherwise, we can, I can,
Once you run through it, I can
Okay.
just jump in.
sure, okay.
Okay,
So in section 10, it establishes 5 new permanent positions. I don't know if they're exempt or classified, so I'll need more information about that and what the titles are.
we'll probably need to have them defined. Because, Nolan, go ahead. You
So I talked to the board about that, and they are gonna give me some position and titles and stuff like that. The question that gets confusing is just to think about the budget and the head model. There's a lot of moving pieces. So the governor had proposed 3. And then you have the additional 2 that's being asked for because the board needs 5 in order to move ahead with the head model.
Mhm.
Then it becomes, or should I call it the head church or whatever you call it. But then there's a piece about, okay, if you create 5 new positions, how does that interact with the head model? If it happens, or if it doesn't happen, and I think we can leave that blank for now because of a lot of uncertainty. I just want to put that out there. So the question is your 5 position in addition to the 3 that's already in the budget, or is it so making it 8 new positions? Or
Well, I
that's
think,
what I want.
yeah, I kind of want to start with that. I know that we need definitions for what those positions would do. And that we can always triage, but I think let's start looking at what those positions would do
Mhm.
in addition to the others.
I just want to make sure because when it goes to appropriations that it's just sort of talking to the budget.
Yeah, exactly. So we are talking with a budget. And
Okay.
so if we have, if there's 3 in the budget already and we want to add 5 and so
The 5 is for the work in this bill.
in this bill,
Great.
and then there's a conversation, what is it that all the positions were needed for this bill?
And my question for Diane then, Diane,
Yeah,
if they do 3, but then they do 5 over here. If they do, because the board said they need 5 to do a head.
Mhm.
So they do 3 in the budget, 5 over here for this. Does that count towards your 5 for the head model?
well, we could get
You know what I'm
back.
getting?
I do, Diane Lamp Green Mountain Care Board. It's gonna depend on what the tasks, if they overlay, depending on where the bill and the other federal model goes forward and how they overlay, they may match up or they may not. So we have to,
So that's what we need to hear from the board.
Yeah.
That's what we need to hear from the,
Those
so like in the
count towards-
bill,
right. So that's why I say,
It's all
let's
a good
put it
start.
all in, we're all
all
in.
in. And then we can
we'll
refine
look for
it.
the river card, but we're looking, we're all in, and then we want to know what the definitions of those are. And if you find that there's overlap, boom, we take a position out, right? That's what we need to look at.
So I'm gonna walk away thinking we need to bring you definitions for 8. 3 that's in the budget,
Correct.
2 that we've asked for, that would be ahead, and 3 more here, that would be a total of 8.
If we're putting 5 in this bill, so I need to know which
We
5.
just
go in
need
this-
5 in this.
5 in this.
But you can give me all those 8 anyway and just tell me which 5 go.
Right. We just have 5 go in here.
Great. Yeah, that's it.
And then there's intent language about authorizing the establishment of 5 more in 27, 5 more in 28. So to actually do it.
Right.
So currently, there's about $2 million in this bill that I've listed, but we haven't gone through what all those things are and
Right,
what
so
needs to
that's-
help us with it.
So that,
And that is let me just say something. I know people are sitting around the room and say, oh, we could put that money into this, that, and the other thing and saving costs for premiums. Guess what? If we do this, we'll be saving huge costs in premiums and it's a drop in the bucket. So I don't do that. So just flow. Sorry. Hello, Nolan, help us.
Yes.
Okay, so then we get to the appropriations. And so the first appropriations are the AHS appropriations, 500,000, of which 250,000 is for grants to hospitals as needed for their transformation efforts under Act 167 and to transition their systems to implement reference-based pricing. 50,000 is for expenses associated with development of statewide healthcare delivery plan. So that may change if you're giving them the main responsibility. And 200,000 for contracts for consultants and other expenses associated with the implementation of the act. There's more specificity you can put on that.
We probably need to put more specificity on.
I don't know. I mean, I don't know if you have,
That's a question for AJ.
yeah, I don't know
Yeah.
if HS has thoughts on.
We can share with you some information that might be helpful in guiding what similar work has looked like or cost or the resources that have been required. But as you know, we can't advocate for resources outside of the government.
Understood. Understood. You support that action. No,
And then there'd be sort of unwritten rule or kind of would be like, how much of any of that work could be Medicaid matched? Probably only a small bit, if any, but just fine. But for now, I would recommend general fund and we can fix that.
okay,
And then we have 250,000 from the HIT fund to the Agency of Human Services to grants to healthcare providers for data integration in accordance with Section 8. And then we have funds for the Green Mountain Care Board. So currently in the bill, we have 1.3 million from the general fund, of which 750,000 is for those 5 positions.
So I have an updated number on that. The 5 positions would cost $802,500.
801.
802,500.
Very specific.
So the board spent some time thinking about what we can get.
And we what? Oh, right. Thank you.
Oh, she got it.
Thank you. I had not written it down. All right, so, is it sufficient for our purposes to do 800 or do we have to?
I think that's fine.
802?
I think that's. If you want to keep it clean, you could take that off the 500, you keep it at 1.3 or.
All right, well, so as we get into it may end up being more. So there's 500,000 for contracts, including contracts for assistance with implementing reference-based pricing. So there we go. We didn't even need that as a reference. And 50,000 for expenses associated with development of the statewide healthcare delivery plan. So 2 questions. 1, does the board need the money for the plan or should more go to AHS if AHS is in charge of the plan?
Probably the latter.
And the second is we talked about giving the board some money to having them report on implementation. No, we've talked about giving them money somewhere. Yes, for consultants to help standardize hospital budget data submissions. Maybe you want to change that 50, I don't know how much that goes. Maybe you want to change their 50 to go for that purpose and then.
Oh, that's a good idea. Would that go over to a different? Yeah, the general fund. No, it would be out of
Sorry,
it.
I lost you.
If it's standardizing hospital budget data submissions, we'd have to
Oh,
look
no.
at, well, we'd have to look at the extent to which those are
Because they have
dependent.
the IT fund, I think.
Well, and you probably might have to make some tweaks to the IT spec.
Can you think about that?
So, what are we thinking about? I'm sorry.
Now, how to use the IT.
So, a contract with a consultant to help standardize the hospital budget data submissions under I'm gonna forget what the word is. What's the system?
Let's say like unified or
Adaptive.
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 I mean, the HIT has really been more about hospital records and claim, so I don't know. I mean, you can do what you want with it. Hasn't always been.
I have to look at the language.
Okay,
Yeah.
and
let's look
see
at the
what's
language.
permissible and
See what
whether
we
you want to
That would be helpful,
modify
I
what's
think.
permissible. I mean, I think it is electronic submission of
Yeah,
hospital data,
yeah.
budget data. So in that sense, it may be, but,
There's money there to do it.
Yeah, you had said that before,
Yeah,
so that's
so
good catch, Jim.
Um, and do you want to increase the amount to AHS, or do you want to keep it at 50,000 and see what's required? I don't have any sense for what's.
Why don't we put it all in one place and then it
Okay.
becomes a lot easier to use.
So that would be,
I just added. 2,000,000. 2,000,000. And 50,000.
For this. What's happening?
That was just what's on the.
Yes.
record,
Yeah.
Not including these addition for 800.
Not.
No, it wasn't an addition of 800 as a change from 750.
750 to 800.
Yes, to
Yeah.
50,000.
50.
right, but now we've also added another 50,000 to,
AHS.
AHS.
Are you leaving the 50 in the Green Mountain Care Board too?
Leaving 50 in Green Care Board, but changing the purpose
Okay.
to be the
500.
hospital budget stuff, so it's.
Wow.
So I think we've gone up. And then you talked about wanting an update and maybe some ongoing updates. So update from the Green Mountain Care Board on implementation of reference-based pricing, global hospital budgets. That work. I think you also heard from the secretary that they would like to give you updates on the work of
That would be excellent.
So you just want,
I think with recommendation, yes, we want updates, so.
when and to whom? I mean, is this like a?
The board was, not the board, AHS was suggesting, the secretary was suggesting to the Health Reform Oversight Committee in the fall. I think that's a good way. It kind of gives a springboard to looking ahead, to our work. It really helped, I think, this year with, looking at this bill. And,
Want that
yes,
November-ish timeframe?
yeah, no later than December 31st, no, so. Let's say November, what's good, 15th,
15th.
yeah.
Well,
Or December 1st.
When's Thanksgiving?
Thanks.
I know, that's what I worry about.
You can do birthday in December.
When's your birthday?
15th next week.
This is 18th, we can have vacation.
What's that?
So it's AHS, so I don't know if AHS doesn't take.
What is it,
When in the fall they want to. report.
what's your preference
For the Thanksgiving week.
before Thanksgiving?
So maybe
That's
November
27.
15th.
Yeah, let's do it.
So that report is Green Mountain Board
You
and.
don't.
No, just AHS.
Yeah.
Yes, this is just AHS, and then you do separately have the board, because the board's reporting on other things. They're reporting on their implementation of reference-based pricing and global hospital budgets, because you were concerned if they weren't going well, you would want to know.
We can hold those presentations.
I'm just saying updates.
Yeah, updates.
Yes.
Yeah. so What,
You want
February 15th, that's when we had something else
when
coming.
you have the first meeting.
The first advisory committee meetings. What? Really, no one's listening. I guess ready to say something.
Not on this.
Okay.
All right, but February. Okay.
We should.
Okay.
Okay, and then I have just the effective dates, the money stuff that costs money to expect on July 1st, everything else to expect on January.
Did we make a decision on section 6, whether BPQ is in on the delivery plan? The only reason I ask is I did get an email from them. They would need resources. It's not a lot, but they would need some resources.
I think we heard they're on the steering committee.
That was for the advisory.
Oh,
This
what
is
are we?
for the statewide. This was section 6, the state health delivery plan where you have
Yes,
the
page 14.
page 14.
Oh, page 14.
So they gave collaborators, the board and the HS in collaboration with DFR and BPQ about the healthcare delivery plan. So they were watching and they emailed me and said they would need some resource. So I'm just throwing that out there. We were talking appropriations. They need a lot of resources. They said like,
Find some.
Yeah,
Hey,
So-
I'm just thinking,
so
I'm
there's-
looking at Monica.
so the email I'll say is
I'm on page 14, and what was your comment? What would be your comment there? We did add we did not. Did we add the healthcare advocate?
we did.
Yeah, okay. All right, think about that one, please.
Right.
It's a
Yes.
be able to engage in his work, BPQ would indeed need resources, maximum of a 0.5 FTE. So,
Maximum of equipment.
yeah, maximum of a 0.5 FTE. So it's not a ton of money, it's maybe $50,000. But it's an appropriation, so who do you appropriate? You don't appropriate.
You would appropriate it to the AHS.
Yeah.
Right. Go to AHS.
Now, or, yeah,
Okay.
so just flagging that to the appropriations for you to consider. Do you want to add that there?
Well, you do have 100,000 now for expenses associated with development of the plan.
Yeah.
Maybe that can.
Right, and BBQHC,
Maybe that can include engaging with BBQHC.
That's what I was,
okay, that's good.
so you can take them out of the, you know.
No, I don't think they've taken them out.
Okay.
No, we don't want to take them out.
All right.
I have one last thing.
Yes.
On top of page 6, oversight with the reference-based pricing, we left out healthcare applicants who we could have them. On page 6. Good developers and
Oh, right, the list, the people who are part, are they already part of it?
So, no, they're not. Does the committee want to add them?
Okay, where are we at? What,
So this
what
is
are we?
page 6, and this is, the board is consulting with, and we're now gonna say hospitals, other healthcare professionals as applicable, health insurers, and the agency of human services on ways to approach reference-based pricing in an effort to achieve all care lines.
So, yeah, let's put them in there.
Okay.
And we can decide if we want to take them out. but
And
that
maybe we want to
represent
say,
patients, that's kind of.
maybe we
important.
want to say, maximize pay for among mentions and
Yes.
some people not be. Yeah, it's supposed to be. All right, it's an effort to achieve. All right, so 8 minutes.
Thank you.
Okay.
Yes, sir.
I have some questions about, section 10 for the positions.
Section 10.
Yeah,
Wait,
so,
what page are you on?
21, so we're at the end.
Okay.
So my question is, the permanency of the position, so, obviously the ones that are for ed, that's a separate issue, but the ones that are specifically here for agreement pair work to do the bill itself and the plan and what we're asking to do. Once those things are done, like once reference-based pricing is implemented, global budgeting, how permanent do those positions need to be?
Yeah, I mean, these are ongoing initiatives. So once they're, there's the development of reference-based pricing, but then there's the ongoing update of the reference and the implementation of it. I don't know that that goes away.
Okay, my last question was just, under 10B for the intent for 10 more positions. If they're already getting a bunch of positions to do the plan, do they need another 10 more to keep working on it? I don't know.
They had requested, I think, 15 over 3 years. So that's what this is doing. It's, that's, it won't happen automatically because it's intent language, but yes, so it's really up to the committee whether that is something you all want to put in there or not.
And so it goes through the whole budget development and appropriations. Anything else from the committee, some questions? Okay.
How many pages do we not know?
About a half, not even.
I know you added some
some stuff.
I know.
It's just to be not enough.
I don't,
It's not like-
my prediction is it will be more,
It's one bill for all the
It's not
stuff that's in it.
it will be longer.
Right, so here's where we are. We've got another issue coming into the room very soon. And Jen is gonna walk through S53 with us again.
Not again, I don't think.
The first time, but we've been working on previous iterations of things. But so here's my suggestion. Look, Jen, what is our life like between now and tomorrow morning?
What are you having for breakfast? What's in your tea?
I'm gonna write out some goals and I'll get those to you that we had talked about in here. And it's not, it's some ideas for suggestions that would be introduction to the bill. Yeah. I mean, that's you, but then what?
So I believe my direction is to create a new draft based on everything you have discussed here and bring that to you at 8 o'clock tomorrow morning.
Right, and so committee, I would, with understanding, we'll start at 8 o'clock tomorrow morning. I'm gonna try and get here on time. This morning, it would have been a tough.
Meeting with the governor.
Well, you can catch up. We're gonna start at 8 and see what we can do. We have some bills scheduled to go through, that I think are important for us to look at prior to crossover. Not sure, some of them are markup and there could be a potential vote on S36. The other two, and possibly S63. We've had information from the board that would help us move S63. We'll look at that again. We're taking out that one section on due process that eliminates due process, and that.
Well, I would argue it doesn't eliminate.
No, it doesn't.
But it's a controversial portion.
Thank you, Jen. It's controversial, and the board has agreed to take that out. So we can look at that bill. We will look at S36 with some language that's come to us from the agency. And then we'll look at S64. We'll have folks in on that at the end of the morning. That is a bill that we do want to look at ultimately, as well as that's it. And then we'll try to get to the end point of our committee bill. I know the VSEA and the NEA have brought us some language. After looking at the numbers that are in the bill with that set a number of like 200% of Medicare. And I think that I've heard that is problematic in terms of implementation and oversight from the board perspective and others. So we can talk about it again, but I'm thinking that unless this would be doing what we had wanted to do with a 2025 implementation date. We would have wanted to start with the hospitals and make it happen, but it is problematic. And I know I was very excited when I heard about the proposal initially and heard that the board might be in favor of going ahead and working on it. But now I'm not hearing that is something that it's administratively difficult. So I'm just going to end it there. And we can have a discussion about that. And I know there'll be hallway discussions going on, but it's if you carve out a group, even with balanced billing, it's going to have a spillover effect. So leave it at that for now. Oh, thank you, Jen. And let's do this. Let's shift over. So please go through your thinking on the bill. I'll see you tomorrow morning. When we end the committee later, we'll again work on this bill at 8 a.m. tomorrow morning. I don't promise breakfast, but I will try. I won't promise coffee. I might promise something.
Your predecessor used to bring
Huh?
us, your predecessor used to bring us stuff.
Rick, do you want me to put up S53?
Yes, please. Okay.
Tomorrow morning, Madam Chair, this, your committee bill, you're taking up at 8?
Yes,
Thank you.
yes, thank you. Yeah. Thank you, Chad.
Okay, we are looking at, so shifting gears here, we're looking at S53, which is an act relating to certification of community-based perinatal doulas and Medicaid coverage for doula services. Just by way of a little background, there was a proposal that was looked at in this committee last year to have Medicaid coverage for doula services, and there was interest in creating some sort of a licensure certification process for doulas prior to requiring Medicaid coverage. And so the Office of Professional Regulation was asked We perform a sunrise review where they look at the most appropriate way to regulate a profession, and they came back with a report that is on the website that would call that recommended certification for a subset of doulas who are community-based perinatal doulas. So we're going to look at the definitions, and then there's some general Medicaid coverage language based on some work last year. So this adds a new chapter in Title 26, which is the professional regulations or professions and occupations title on community-based perinatal doulas, and has a number of definitions. So some of them sort of interrelate. The first one is certified community-based perinatal doula, and that is a community-based perinatal doula who is certified under this chapter. Community-based doula is an individual who provides doula services to under-resourced and marginalized populations at low or no cost, often through a community-based agency. A community-based perinatal doula is a community-based doula who provides doula services to individuals during the perinatal period, which also is defined. A doula is a non-clinical, non-medical individual who provides direct emotional and physical support and educational and informational services to birthing individuals before, during, and after labor and childbirth. So it's very kind of around, all around. Very is around or surrounding, around birth and delivery. So prior to, during, and after. And perinatal is the period of time encompassing pregnancy, childbirth, and up to 1 year postpartum. All right, it starts off with prohibitions and penalties. Nothing in this chapter should be construed to prohibit the provision of doula services by a non-certified individual. So it's okay to still be a non-certified doula, provided that no person shall use in connection with their name any letters, words, or insignia indicating or implying that they are a state-certified community-based perinatal doula unless they are certified under this chapter. And there's penalties for violations that are in the general OPR statutes. Duties of the director. This is the director of OPR, the Office of Professional Regulation. The director shall provide general information to applicants for certification as certified community-based perinatal doulas, receive applicants for certification, grant and renew certifications in accordance with this chapter, and deny, revoke, suspend, reinstate, or condition certifications as directed by an administrative law officer. The director shall explain appeal procedures to certified community-based perinatal doulas and applicants, explain complaint procedures to the public, prepare and maintain a registry of certified community-based perinatal doulas, administer fees collected in accordance with this chapter and the OPR statutes. So go down home, refer all disciplinary matters to an administrative law officer under the OPR disciplinary statutes. And it allows the director, after consultation with advisor appointees, so you'll see in a future section, may adopt rules as needed. The advisor appointees, this is that later section, Secretary of State shall appoint 2 certified community-based perinatal doulas to serve as advisors. So this is an advisory board model of OPR regulation. Advisors in matters relating to community-based perinatal doulas will be appointed as set forth in the OPR statutes and serve at the pleasure of the secretary. One of the initial appointments may be for less than a full term, and appointees can have not less than 3 years of experience providing community-based perinatal doula services immediately preceding appointment and be actively engaged in the practice during incumbency. The director must seek out the advice of the advisors in carrying out the provisions of this chapter, and the advisor appointees are entitled to per diem compensation and reimbursement of expenses as permitted under 32 VSA section 1010. Eligibility: in order for someone to be certified as a certified community-based perinatal doula under this chapter, the applicant must complete and submit an application in the manner prescribed by the director by rule, send in the applicable fees, and provide evidence satisfactory to the director that the applicant is at least 18 years of age, has sufficient and appropriate competencies in community-based perinatal doula services, whether acquired through experience, mentorship, training, formal education, or a combination of these as determined by the director by rule. And they must have passed any criminal history background checks or registry checks required by the director by rule. The certification will be renewed every 2 years upon application and payment of the required fee, and proof of compliance with any continuing education or demonstrated competency requirements established by rule. Unprofessional conduct means misusing a title in professional activity and any of the conduct in the OPR unprofessional conduct statute, whether committed by a certified community-based perinatal doula or an applicant, and it allows OPR to discipline someone for unprofessional conduct as provided in relevant statute. Section 2 is just adding community-based perinatal doulas to the list of professions attached to the Office of Professional Regulation. Section 3 adds community-based perinatal doulas to the list of applicants for whom the office may inquire into criminal background histories. Section 4 is the fees. This establishes a $75 application fee for community-based perinatal doulas and a biannual renewal fee of $120. Section 5 gets into Medicaid coverage for doula services. So it uses that same definition of certified community-based perinatal doula, requires the Department of Vermont Health Access to provide reimbursement to certified community-based perinatal doulas for providing direct emotional and physical support and educational and informational services to birthing individuals covered by Medicaid during pregnancy, labor, delivery, and postpartum period, regardless of the outcome of the pregnancy. And it does specify that the doula would not receive reimbursement for travel time or mileage expenses. It expresses legislative intent language that was in the bill last year as well, that the General Assembly intends that DVA reimburse qualified doulas in amounts that are reasonable and adequate for the services provided and consistent with the reimbursement rate set by other states' programs. That's in lieu of putting specific amounts in statute. It directs Department of Vermont Health Access to seek a state plan amendment from the Centers for Medicare and Medicaid Services if needed to allow Medicaid reimbursement. And then we have effective dates. Certification statutes take effect on July 1st of 2026, provided that the director of OPR must commence the rulemaking process before then in order to ensure that the rules will be in effect by July 1st of 26. Section 5, the Medicaid coverage will take effect on July 1st, or if a state plan amendment is necessary, which I believe it is, upon approval of the state plan amendment, whichever is later, and everything else takes effect on passage. Now I can hear from OPR and
We want to hear from
Community-based
OPR and Maria. Yeah. Is Jen also here?
Yeah, so Lauren and Jen are here.
Okay, this is Jen.
Yes, ma'am.
Welcome, and that's Maria. Okay. So Maria, we'll go to you first and welcome to our committee. We're gonna not do introductions simply because of our time. We'd like to hear testimony. So thanks for being here and go right ahead.
Sure, thank you for having me. So 14 years ago, with the help of Mary Moulton, who was our executive director at the time, I created the Doula Project here at Washington County Mental Health. The Doula Project provides prenatal birth and postpartum community doula support to those who receive Medicaid assistance and qualify for services. Our funding is a mix, relying on grants and scholarships to pay for birth support. We are community doulas. Community doulas provide intensive, longer range support with an emphasis on culturally congruent, community-based care to underserved individuals and families, as you just heard from OPR's description. I also co-founded our statewide doula group, the Doula Association of Vermont, and I'm here today as a legislative and advocacy arm of DAV. I'm so grateful and excited to see the state of Vermont commit to maternal and infant health, especially for the most vulnerable families in our communities who often experience the worst outcomes. Almost 40 years of data tell us clearly that doulas improve medical and mental health outcomes of birthing people, including reduced risk of premature birth, cesarean birth, higher rates of breastfeeding, and lower rates of perinatal mood and anxiety disorders. doulas are also in a unique position to provide early intervention support when families are struggling. Doulas are a protective factor for families and have gone underutilized for far too long. Dr. John Kendall, a pediatrician and researcher, once said, if a doula were a drug, it would be unethical not to use it. DAV wholeheartedly supports OPR Sunrise report on certifying community-based doulas in Vermont. DAV worked closely with OPR with their Sunrise study process. They were incredibly collaborative to work with. OPR guided us on community engagement, supported families to share their experiences, shared our training and experiences as doulas, and provided relevant data and studies done in other states. 25 states are implementing or have already done so, giving us an opportunity to learn from them. We found OPR to be thoughtful, thorough, and committed, and the Doula Sunrise study reflects that. DAV supports the findings and recommendations of the Doula Sunrise study, and we ask that you support the bill this year. I helped to write the first bill 8 years ago, and I'm so grateful to be sitting here talking to you about this today. We've been working hard to bring this work to fruition, and it means so much to so many people. I thank you for listening, and also welcome any questions.
Thank you. Questions? Okay.
Thank you, Maria.
Yeah.
Thank you.
Terrific. Thank you for your work.
Thank you all.
So Lauren, you're next.
I'm gonna just put Jen Colin in a seat if that's okay.
Sounds very good. But thanks for being here.
Oh,
I
yeah,
know, I know your life is busy right now.
I'm happy to be, and this is something that our office supports very much.
Good. Okay.
Good morning. Good morning. Change that sheet. Yeah.
Now it's my call. I
Have we
Welcome.
Good morning. For the record, my name is Jennifer Colin and I'm General Counsel for the Office of Professional Regulation. Thanks so much for having us here today to testify about our work related to community-based perinatal doulas. We're very, as Lauren just said, very passionate about this effort. We did file testimony this morning, so hopefully you received it, and I'm just going to go through that testimony. Happy to take any questions. Just to cut to the chase, OPR fully supports S53 as the proposed bill implements a certification program for community-based doulas and allows for Medicaid coverage of the critical support services that community doulas provide within their own marginalized and under-resourced communities. In our testimony today, we're going to provide the committee with an overview of our recommendations. Then we're going to talk about the research testimony and information that led to those recommendations. And then finally, we're going to discuss what the next steps for OPR would be upon the passage of the legislation. As you all likely know, the Office of Professional Regulation regulates over 50 diverse professions, and we have over 84,000 individual and business licensees. We offer 3 forms of occupational regulation. Those are registration, certification, and licensure. Registration is the least restrictive form of regulation and requires that all practitioners in a profession register with OPR by filing an application and paying a fee prior to rendering services. Registration does not require education, experience, or examination. And I see there, hopefully that I see an error in my testimony that I've got in front of me. Hopefully it's not in yours. The next form of licensure I'd like to talk, or form of regulation I'd like to talk about is licensure. And that's the most restrictive form of professional regulation. Licensure is mandatory for all practitioners within a profession, and it requires achievement of specified qualifications such as education from an approved educational or training program, experience, and examination. And then finally, we have certification. That's a voluntary credential that a practitioner may obtain upon meeting certain requirements, such as approved training or educational programs or mentorship or however the certification program is structured. It's not required of all practitioners in a profession. Those who want to call themselves a certified X, whatever the profession title is, they're required to get that certification from our agency when we offer certification. So for doulas, OPR recommends a regulation of a subset of perinatal doulas, and that subset is community-based perinatal doulas. We're not recommending regulation of the entire profession. We think that would be over-regulating where there's no demonstrated need for kind of additional public protection. Really, in the community-based doula space, that's where OPR has determined that regulation would be appropriate. OPR recommends certification as the appropriate form of regulation. Consumers of community-based perinatal doula services may have a substantial interest in relying on qualifications and training of doula practitioners. Thus, a voluntary credential that signifies that the practitioner has achieved required competencies through training, experience, and/or education would be the least restrictive form of regulation necessary to protect the public. So next I'm going to just talk a little bit about the bases for our recommendations. And you've probably heard some of this testimony already, so forgive me if I'm duplicating. Perinatal doulas are trained, non-clinical, non-medical support people who provide emotional, physical, educational, and informational services to birthing individuals before, during, and after birth. Doula services have traditionally been private pay, thus they've been limited to folks of financial means. Community-based doulas provide these support services to under-resourced and marginalized populations at low or no cost, often through community-based agencies. And as you all know, you heard testimony last year about the maternal mortality crisis in the United States. We have an alarmingly high rate of maternal mortality in the US, higher than in other developed countries. In 2021, that rate rose significantly and was 32.2 deaths per 100,000 live births. And within that US maternal mortality rate, there are significant disparities depending upon race and economic status. So, for example, the maternal death rate for non-Hispanic Black people was nearly 3 times the rate for non-Hispanic white people. Rural populations have significantly increased rates of maternal mortality due to pregnancy-related complications, and Medicaid recipients are 80% more likely than privately insured folks to experience severe maternal morbidity, which the CDC defines as unexpected outcomes of labor and delivery that can result in short or long-term health consequences. Severe maternal morbidity has serious impacts on women's health, and it also significantly increases the cost of medical care. In Vermont, approximately 38% of all births are covered by Medicaid. And between 2021 and 2023, 8 perinatal maternal deaths occurred in Vermont, and all 8 of those individuals were receiving Medicaid. So, obviously, OPR has determined, and other speakers that have been testifying to have identified that doula support reduces poor outcomes and improves patient experiences. Over 60% of maternal deaths that occurred in 2021 were preventable, according to the CDC, and studies have shown that perinatal doula support substantially reduces birth complications, C-section deliveries, low birth weights, epidural use, postpartum depression, and anxiety rates. Doula support provides better birth experiences for patients, improved maternal outcomes, and better breastfeeding outcomes. Based upon the legislative record that OPR reviewed in connection with the Sunrise study, the intended regulatory purpose of the doula profession is to ensure equitable access to this important doula care for birthing persons in under-resourced and marginalized communities to improve their health outcomes. Community-based doulas serve Vermont's most vulnerable birthing population. They are a subset of the profession for which specialized training and experience will demonstrate that they have the necessary competencies to serve communities experiencing disparate health outcomes. And those health outcomes result from systemic biases, structural racism, poverty, substance use disorder, mental health disorders, housing insecurity, trauma histories, developmental disabilities, and the like. A tenet of community doulas is providing culturally congruent and competent services to birthing persons of shared cultural communities and languages. Community doulas are part of an asset-based approach to support underserved communities, meaning community strengths and assets are used to give community members more control over their own health. Whereas in a deficit-based approach, solutions for identified problems or deficiencies are often developed outside of the community. Voluntary certification of community-based doulas will be a valuable market indicator of competency for Medicaid to cover these crucial services for communities experiencing disparate rates of poor maternal outcomes. In our Sunrise review process, we engaged with a lot of stakeholders, other state agencies, advocacy organizations, doulas, general members of the public. And in that process, everyone kind of overwhelmingly supported certification of community-based perinatal doulas. The report identifies that the primary concerns of stakeholders were ensuring that our certification pathways are flexible so that we can recognize competencies achieved through experience as well as formal education. We're trying to make sure that we're not imposing insurmountable barriers so that people from within marginalized communities can get this certification and assist those within their community. Stakeholders were wanting to ensure that we resist restrictive regulations that discourage doulas from marginalized communities from seeking the credential. Stakeholders wanted to be sure that OPR implements appropriate regulation to help build a workforce with culturally congruent and competent professionals who have lived experience in the communities that they're trying to serve. And stakeholders wanted OPR to be sure to support community-based doulas so that all birthing families can benefit from the improved birth outcomes and experiences and be connected through those community-based doulas to important resources like housing and food support and stuff. Assuming passage of this important legislation, OPR will need to set up infrastructure within the agency to regulate the profession. Previously, we provided I had an error in my previous testimony. OPR estimates that this will cost approximately $25,000, and we're asking for a general fund appropriation so that we can do the IT setup, stakeholder outreach, administrative rulemaking, so that would be it would be helpful to have a fiscal note for this bill since it is an ask out of the general fund. And if this policy becomes effective, OPR will need to immediately begin rulemaking process so that we can make sure to meet that July 1st, 2026 deadline. Thank you so much and happy to take
Thank you. Thank you for all the work you've done on this. I know it's a very important bill for us and for others, and we appreciate the time that you've taken.
Yes, ma'am. It was a pleasure.
Yeah, terrific. And so Senator Gulick has a question.
Jennifer, thank you so much. That was great, thorough, and
it flowed nicely. It's great to read. So thank you. My one question, when you collaborated or reached out to other agencies, did you happen to speak to DEVA at all?
We did. Alex McCracken from DEVA was involved in some of our meetings, and so they were part of the process, and we expect to collaborate with them significantly in the rulemaking process. So we already have that a strong connection there. Great.
I might.
Yes, please.
Well, join this office. There was also last year, there was a report required from
Yes,
Diva on coverage of dual services, and it is in the Medicaid budget book on page 54. So maybe we can send a link to Kiki and she can post it.
That
But
would be
in
great.
there, it's a lot of useful information about what it would look like
that'd be great.
and cost.
Okay, so we don't need to hear from them, really. We've got it.
You could. It's up to you.
I might ask them for a memo to support that. It would be good. And I've asked to have that come in tomorrow.
Great.
Any other questions? So committee, we're gonna put this up tomorrow for a vote. We've worked on this. I know you guys haven't worked on it previously, but you can hear the amount of work that's gone into this bill. Go ahead.
Wait, so it looks fine to me. I'm finding a vote right now.
What?
There's a couple things I might recommend you add to the language before you vote.
Okay, good.
You need an appropriation.
Yes.
Two appropriations at least. One would be 25,000. Second would be you have per diems in here. So you, I don't know that you need an appropriation for the per diems, but it does have a cost.
Right.
And third is, I have to kind of go through what the Medicaid impact would be.
Okay.
And, I can do a fiscal note, but I'm just saying, you at least need a 25,000 appropriation for OPR.
Okay.
Do you want to do that in here?
Yeah.
or in-
Well, if we can do it, that would be great. And that can also have an appropriations, but I think if we can do it, if Jen, if it doesn't overwhelm,
I'd recommend you at least do that.
yeah.
So that's
Yeah,
going
let's
to
do that. Okay, and then what we'll do is we'll have this
Well, there's
tomorrow.
fees too. so
Vote on it. I know that.
Yeah.
What Lauren, someone is coming in from your office again tomorrow.
It'll be Jen.
It'll be Jen. Oh,
Yeah,
great.
I'm
That's
not
good.
available tomorrow, so
Oh,
she's
we like that.
gonna sit
Okay,
in your
and
seat again.
so we'll vote. We're gonna vote on this tomorrow.
That's
That's 53. Tomorrow.
also fees.
Thank you.
Great. Thank you so much for having us.
You're welcome.
Thank you. And we